Hi guys, today let's talk about hemochromatosis. Before we go into the pathology of the disease, let's look at how normally iron is circulated in the body. So, iron can be in the diet as a ferrous or a ferric form. Once we consume some iron, it goes down into the duodenum. And let us zoom into the duodenal villi and let us zoom into one enterocyte. So, ferric iron is converted into ferrous iron by the duodenal cytochrome B, and then ferrous iron is taken in through the DMT1 into the enterocyte. And then from the enterocyte, with the help of ferroportin, it goes into the circulation. In the circulation, it is aided by transferrin, which carries the iron in the circulation. The main function that transferrin performs is in the circulation, it carries the iron and it mainly contributes to sending iron into the bone marrow for erythropoiesis. We need iron to make RBCs, right? And then when the RBCs have completed their job, their duty is over, they come to die in a macrophage. Once in a macrophage, iron is released again, and there's a ferroportin in a macrophage as well, and it is sent back into circulation, the iron. So, this is how iron circulates normally. This is how there is turnover of iron in the body. The way it is excreted by shedding of skin cells, hair, a little bit in the sweat, and a little bit in the urine and feces. This is not significant in amount. Now, how is the amount of iron regulated normally? What happens is we have our transferrin and iron here, right? The levels of this are detected by certain receptors in the hepatocyte. We are zooming into a hepatocyte right here. So, in the hepatocyte, there are receptors called HFE, TFR1, and TFR2, which detect the amount of circulating iron in the body. And based on that, they signal a very important molecule to release. They induce the release of something called hepcidin. HJV induces a signal to hepcidin based on iron stores in the liver itself. Liver iron stores cause this to signal hepcidin coming out. Now that these receptors have realized that there's quite enough iron in the body and that is sufficient, hepcidin, once released, makes sure that there's no more absorption of iron in the body. It regulates the absorption of iron. So now that we have enough iron in the body, hepcidin makes sure that the absorption is stopped and no more iron is taken up. So, what is hemochromatosis now? Hemochromatosis is a condition of iron overload. When does this overload happen? If there's absorption that is much more than normal, then hemochromatosis will happen. So, primary hemochromatosis is a condition on its own and it occurs due to mutations in HFE or HJV. There are some which occur due to mutations in the ferroportin as well. But the most important, the most common is a mutation in HFE. Hemochromatosis can come secondarily due to iron overload. Now, this can happen in conditions like thalassemia or sideroblastic anemia, conditions where people are getting constant blood transfusions, and these blood transfusions will lead to a lot of iron buildup in the body. So, secondary is due to other conditions that are causing iron overload. Primary is a condition of iron overload by itself. So, when there's a mutation in one of these receptors, they're not going to detect the circulating iron properly and they are not going to signal hepcidin to stop the absorption of iron in the duodenum properly. So, when they don't signal hepcidin to work, then what is going to happen? An increased amount of absorption, more than what is required. And that is what causes primary hemochromatosis. Something interesting to note is iron accumulation in primary hemochromatosis takes place in the hepatocyte itself. But in cases of secondary hemochromatosis, iron accumulation happens in macrophages of the liver, which are called Kupffer cells. Clinical manifestations. Please note that the total body iron in a normal person is about 4 grams. But in a person with hereditary hemochromatosis, this is going to be up to 20 to 60 grams. Now, this is not going to happen in, a year or two or something, because there's accumulation of iron over many years. Because in dietary iron, we're not going to get like extreme amounts of iron, right? We are going to consume a certain amount of iron each time we eat, and over the years it's going to accumulate to the point of coming to 20 to 60 grams. So this will usually manifest at 40 to 60 years of age. So it happens at 40 to 60 years of age. Now it manifests late in women. Can you guess why? So because women have menstrual cycles every month, they're going to be losing some amount of blood. So the iron accumulation in the body is going to happen at a slower rate in females. So women present a little later due to menstruation. Next, please do note that this is autosomal recessive disease when we talk about HFE mutation. First organ affected is usually the liver, and there will be hepatomegaly, and cirrhosis can also happen over time. And cirrhosis, in 30% of people with cirrhosis due to hemochromatosis, they move on to get hepatocellular cancer, and this is a major cause of death. Second, there's going to be iron deposition in the pancreatic islets as well. So these people will likely develop diabetes mellitus. Third, there's going to be pigmentation of the skin as well. There's a grayish pigmentation of the skin in places like the axillae and the groin, where there's a lot of exposure and there's a lot of melanin. This deposition happens, and there is, like I said, hyperpigmentation. And this diabetes and hyperpigmentation together is a characteristic feature of hemochromatosis, and this is called bronzed diabetes. There's also going to be pseudo gout due to chondrocalcinosis. So there might be attacks of pain, and when you check it out, it might feel like pseudo gout, but it is occurring primarily due to hemochromatosis leading to this. There's also going to be disturbances in the pituitary as well and the genitalia. So there's going to be testicular atrophy. There's going to be loss of libido. There's obviously going to be fatigue. There will be arthralgias. There will be arthritis, arthropathy, with diffused demineralization of the bones, and there's loss of articular cartilage as well. And in the heart can cause arrhythmias and cardiomyopathy. On to the diagnosis. Plasma iron concentration is increased. What happens to the plasma iron binding capacity? It's going to be more than 70% of it is saturated. Now, this is a very sensitive marker, the transferrin saturation. So if there's a lot of iron that is circulating, it's going to be carried by transferrin, right? So transferrin is going to be highly saturated with a lot of iron. So transferrin saturation is elevated, which is more than 45 to 50%, and this is very sensitive. Serum ferritin will also increase, but this is not as sensitive. It happens in a lot of other diseases like alcoholic hepatitis, non-alcoholic steatohepatitis, and it also acts as an acute phase reactant in many other inflammatory and neoplastic conditions. You can also see increased liver density on CT because of the deposition of iron. And you can catch hepatic iron even on MRI. Lastly, if you do a biopsy, you will see that there is deposition of iron and there is hepatic fibrosis and cirrhosis. Now, how do we plan to treat it when we see it in one of our patients? So what you want to do is you want to do a bunch of venisections. You want to do phlebotomy. That is just as drastic as it sounds, that's what you do. You do a weekly venesection of about 500 ml blood. You do that until the serum iron is normal. This may take up to 2 years, until it is normal for almost 2 years. Then you still continue the venesection to keep the iron ferritin normal. So you continue this. Some people cannot tolerate venesection because they might have severe cardiac disease or they might have anemia. So in those people that can't tolerate venesection, you can go for chelation therapy. So you can do chelation with desferrioxamine, and you want to treat the cirrhosis and diabetes mellitus. You want to keep taking care of any congestive heart failure that might develop and potential arrhythmias. You have to keep monitoring how the heart is doing. Something that you should remember is vitamin C actually aids iron absorption. So you want to avoid supplemental vitamin C. You know how people are taking supplements of vitamins these days, right? So in a patient with hemochromatosis, you want to make sure that they avoid that. Another interesting thing is that there is a pathogen. There is a microbe called Vibrio vulnificus. Now this is there in raw shellfish or it can be in the sea. This is basically a bacteria that can cause very fatal infections in people with high iron levels. So that was about the pathology, manifestations, diagnosis and treatment of hemochromatosis. Hope you enjoyed this video and do support the channel. Thank you.